for me to introduce the next speaker, which is Dr. Hazza AlZahrani from King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. He is working as a consultant in the section of adult hematology and hematopoietic stem cell transplant in the Oncology Center.
Assalamu alaikum. It's my honor and pleasure to be with you today, and I'd like to thank all the organizers for giving me the chance to present to you the brief overview on the management of VTE using direct oral acting or direct acting oral anticoagulants. So what is the oldest anticoagulant known for in the recent medicine? Which one? No, actually it was lipuridine, which is not lipuridine, herodine. Herodine is the natural anticoagulant present in the saliva of Herodina medicinalis, which is the leeches. They use it to do venesection in the old past. So this is the oldest anticoagulant, and then the next is the heparin. So this is the outline of my talk. And the heparin was discovered in the late 30s. Then warfarin was discovered in the 40s. And these two drugs remain the mainstay of therapy of venous and arterial thromboembolism for almost 60 years, and they remain very important drugs that we use on a day-to-day basis in managing venous thromboembolism. In a trial to avoid the unwanted limitations of the unfractionated heparin, low molecular heparin was made, and there are now at least 4 or 5 low molecular heparins available in the market for management of DVT and pulmonary embolism. And they have been shown to be as good and safer, actually, with regards to bleeding and with regards to the risk of heparin-induced thrombocytopenia than unfractionated heparin. So there is more than 20 years' experience with extensive literature on the use of low molecular heparin as an effective management of venous thromboembolism. Then argatroban was introduced, and this drug is only used now in heparin-induced thrombocytopenia. Bivalirudin, which is a derivative of lipuridine or herodine, recombinant protein, was made available in the 2000. Fondaparinux, which is a synthetic pentasaccharide, which only has the 5 pentasaccharides of the effective part of the heparin and low molecular heparin. It was introduced and approved in 2001. But the most recent drugs that are used for managing venous thromboembolism are dabigatran, rivaroxaban, apixaban, and edoxaban. And the phase 3 trials for these drugs resulted in huge amounts of data that created good foundation on the recommendation for management of venous thromboembolism at this time. Now, venous thromboembolism is a common disorder affecting 1 in 1,000 person and in overall, and 5 in 1,000 people in those who are above the age of 70. And they are associated with significant morbidity and mortality. The 30-day mortality of pulmonary embolism can be up as high as 31%, for DVT around 3%. And there are also serious long-term complications of venous thromboembolism, including post-phlebitic syndrome that can be seen in 20 to 50% of cases of DVT, and chronic thromboembolic pulmonary hypertension, which is one of the devastating complications of recurrent pulmonary embolism. It manifests basically with severe shortness of breath, with a significant limitation of the functional capacity of these patients. And it happens in 2 to 4% of patients with pulmonary embolism. Also, the quality of life of these patients is affected, and the cases of VTE can be a major health cost burden to the hospitals because of inpatient stay or outpatient visits, and because of readmissions, because of the drugs itself, complications of the drugs, or the underlying disease. Now, this is very well known to all of you. The current treatment of venous thromboembolism is divided into 3 phases. initial treatment, which is up to 10 days, then what is now called long-term treatment, which is 10 days to 3 months, and then 3 months of after 3 months for up to indefinite period. Treatment is then continued depending on the risk-benefit of each individual patient. Risk of anticoagulation, risk of recurrence, and the benefit of the anticoagulation with regards to the reduction of the recurrence of these events. Now, the initial treatment, the old but remains valid for some patients, intravenous unfractionated heparin, that is given in the usual and well-known method to you, initial bolus of 80 to 100 units per kilogram, then followed by maintenance of 18 to 20 units per kilogram. We don't use this drug at this time, except in those who are at risk of bleeding. So inpatient we just recently had a case of an immune deficiency with big right atrial thrombus, and he has acquired autoimmune Crohn's disease because of this immune dysregulation, and he has a big clot. He needs anticoagulation to dissolve this clot, but he also is at risk of bleeding from actually it was ulcerative colitis, not Crohn's. So we have to strike a very tight balance between the risk of bleeding and the risk of clotting and extension of thrombus. And the best drug in this setting remains intravenous unfractionated heparin. But for more than 95% of patients with DVT or DVT and low-risk pulmonary embolism, sub-Q low molecular weight heparin or the newer anticoagulants are the preferred choices. Now, sub-Q unfractionated heparin, unmonitored, was also studied and proved to be as good as low molecular weight heparin in a study done around 15 years back by Caron. The study was called FIDO. So they give us 17,500 units sub-Q twice daily, up to 3 months, and it was as good as low molecular weight heparin. Now, in the long-term treatment, the choices are here: vitamin K antagonists, rivaroxaban, apixaban, dabigatran, and in cancer patients, low molecular weight heparin remains the best choice until now. And there are ongoing studies, as mentioned in the previous session, on the use of new oral anticoagulants in cancer patients, and this is still not recommended as a treatment for cancer patients. The conventional therapy with heparins followed by vitamin K antagonists is safe and effective, but it also has some limitations, including parenteral injections, delayed onset of action, the need for frequent monitoring, and the interaction, especially with the vitamin K antagonists, with multiple drugs and food. So balancing the risk of bleeding from anticoagulation and the risk of progression of thrombosis, by judging each individual patient's clinical factors, you can decide on choosing the appropriate anticoagulant for each individual patient. So guidelines still remain general guidelines, but you have to use your own clinical judgment to decide on which drug to choose in individual patients. So if I wanted to dream of an anticoagulant that is ideal and will not have the limitations that I mentioned with the conventional anticoagulants, then I would love to have something that has high efficacy, administered in a simple way orally, low risk of bleeding, given in a fixed dose, so not to confuse patients, and have a rapid onset and offset of action. And as Dr. Aweda mentioned previously, that this may be a drawback in patients who are non-compliant. If you have a short half-life for a drug and he missed the windows, then there's a risk of recurrence of clots in that period. Drugs that's able to bind the clot-bound factors to enhance rapid resolution of the clots, and the drug that has, you can reverse it easily and quickly in case of bleeding or in case of emergency surgery needed. And it has to be affordable. The current price of most of the new oral anticoagulants is in the range of 300 to 400 riyals per month. So they're really affordable. And if you compare to low molecular weight heparin, they are cheaper than low molecular weight heparin actually for long-term use. The new oral anticoagulants are not any more new because they've been approved for more than close to 10 years now. They are directly, this is the other name, direct-acting oral anticoagulants or target-specific oral anticoagulants. And I will show in the next slide what I mean by target-specific anticoagulants. They have rapid onset of action. They have few drug and food interactions. They are used in a fixed dose. They need no laboratory monitoring in general, but in patients who come to you with severe bleeding or requiring emergency surgery, you may have to do the level if the facility is available for you. They have shown better results in terms of efficacy and safety compared to traditional anticoagulation. And so in the past 5 years, the 4 drugs that I listed have already been approved for management of DVT and pulmonary embolism, and they are shown to be less associated with less bleeding. The American College of Chest Physician guidelines have changed their recommendations in favor of direct oral anticoagulants. This was published in February this year. In acute DVT and long-term treatment of VTE, they are in favor of using the new oral anticoagulants because of the characters that I mentioned in the previous 2 slides. Now, when we say target-specific oral anticoagulants, this is what I mean. The new drugs are directed or act specifically as inhibitors of the proteases, the coagulation factors. So any drug that ends with Ixaban means that it inhibits factor 10A. Ixa means active factor 10. Ban means stop or prevent. So rivaroxaban, idoxaban, and betrixaban, and edoxaban, they inhibit factor 10. Dabigatran inhibits factor 2. This is the table showing the difference between the different anticoagulants in comparison with the new oral anticoagulant, with the vitamin K antagonists. So the target of action for warfarin is vitamin K epoxide reductase. And I'm sure you all are aware of the variation in the gene polymorphism of VCOR that makes this wide range of dosing in different patient population, from 1 milligram to up to 30 milligrams, even for different patients, with achieving the same, in order to achieve the same target INR of 2 to 3. Dabigatran is given as an inactive substance and is converted to an active drug in the body. The bioavailability is shown here. So it is lowest for dabigatran. The dosing is once a day for warfarin, BID for rivaroxaban in the initial 3 weeks, and then once a day, BID for apixaban, and twice daily for dabigatran. Once a day for patients with, who require dose adjustment. Time to peak effect is very fast, actually. It takes days for warfarin, but within few hours, you have a therapeutically efficient level of the new oral anticoagulants. As fast as, or even faster than the low molecular heparin given subcutaneously. The half-life is almost around 10 hours for all of the new oral anticoagulants. The renal clearance is very, very important for dabigatran. 80% of the drug is cleared through the kidney, whereas 25% or 1/3 of the level is cleared by the kidney for rivaroxaban and apixaban. No need for monitoring for the new oral anticoagulants, and the interactions are much less than warfarin, but they still can have interaction with P-glycoprotein inhibitors and with cytochrome 3A4. This is the mechanism of absorption in the gut. So they are dependent on P-glycoprotein. So any drug that enhances the P-glycoprotein transport from the gut to the blood can, because it gets absorbed and then effluxed back. So a drug that inhibits the P-glycoprotein will lead to higher level of the new oral anticoagulants. And a drug that enhances the P-glycoprotein, like rifampin, will lower the level of the new oral anticoagulants. So no major interaction with food in the new drugs, but cases where there is disturb vitamin K metabolism, like taking antibiotic for a good time, or the malabsorption or biliary obstruction, can cause additional vitamin K deficiency that may enhance the anticoagulant activity of the new oral anticoagulants. An important point in the rivaroxaban is that the bioavailability of rivaroxaban is enhanced by taking it with meals when given in these doses. Apixaban doesn't matter if you take it with or without meals. And dabigatran, 10% of patients on dabigatran develop dyspepsia and GI upset. So many times you would suggest that the patients get the drug with food just to reduce the dyspepsia associated with this drug. So these drugs actually represent an important advance in management of venous thromboembolism. They facilitate out-of-hospital treatment. They are easier to use, and they are safer than warfarin. I will show you in a few slides. And you can use them in what we call a single drug approach, or all oral regimen, where you don't need a pre-therapy with a parenteral anticoagulation. And this is true only for rivaroxaban and apixaban. For dabigatran and for edoxaban, in the studies that was conducted, they have used 5 to 7 days of parenteral low molecular heparin prior to the start of the dabigatran or edoxaban. But these drugs also have some limitations, including the dosing for morbidly obese people are not clear. Also dosing has to be adjusted, and there is clear guidelines for apixaban in particular for those who have very low body weight. Pregnancy and nursing, contraindications to use these drugs. And patients with serious thrombophilic disorders like antiphospholipid may not be the appropriate population to use these drugs in. Concomitant antiplatelet therapies double the risk of bleeding, especially in elderly patients. And they are not recommended yet for cancer patients and in patients in the pediatric age group. I think we mentioned most of these. They don't need laboratory monitoring. They have a wide therapeutic window, and there is minor interaction with food and drugs. But there are contraindications for these drugs, including the clinically significant bleeding and conditions that are associated with major bleeding, including hepatic disease and other disorders or medications that can increase the risk of bleeding, and of course hypersensitivity. And age and weight we mentioned in the previous slide. Dabigatran is contraindicated in those with renal impairment, where creatinine clearance is less than 30. Also the same thing, but for a much worse renal impairment, down to creatinine clearance of as low as 15. This is a contraindication for using it. Otherwise, you can use adjusted dose of these drugs. We mentioned the weight and age and as possible factors that increase the risk of bleeding with these drugs. P-glycoprotein inhibitors like amiodarone can enhance the effect, especially of dabigatran, and rifampin can lower its effect. Rivaroxaban have a major interaction, as well as apixaban, with azoles. So the level can be increased to more than 70% with the use of antifungals if they are used with rivaroxaban. The same thing is true for vitamin K antagonists, which is very clear to all of you, I think. I don't skip this slide. Now, if you decide that this patient needs reversal because of an emergency surgery or because they have active bleeding, the available methods to reverse these drugs include andexanet, which is a decoy drug that is recombinant factor 10 that has no activity, but this drug can be used for apixaban and rivaroxaban. It is not yet FDA approved to my knowledge. Idarucizumab, which is a monoclonal antibody that clears dabigatran instantaneously, is now FDA approved for use for reversal of dabigatran. And siraparantag is a general reversal agent for all anticoagulants not yet FDA approved. But the available methods to use for patients with active bleeding are PCC, prothrombin complex concentrates, recombinant factor 7, and charcoal in order to prevent further absorption from the gut through a especially effective way for dabigatran, and hemodialysis for dabigatran because it has much less protein binding in the circulation than the other two drugs. And perioperatively, it's very important to keep this information in mind, that you have to know the type of surgery and how, what is the risk of the surgery with regard to bleeding and the renal function of the patient in order to decide on the duration that you need to stop the anticoagulation for before the surgery can be performed. So it can vary from 1 day to 4 or 5 days, depending on the drug and the renal function. I will take you very quickly over the studies that showed the efficacy of the new oral anticoagulants in DVT and PE. And they all are double-blind, randomized trials, except for the Einstein trial, where it's prospective, randomized, open-label, blinded endpoint evaluation. This is the summary of the study on dabigatran. There are 2 studies, RECOVER and RECOVER-2, and there was a huge number of patients, close to 5,000 patients total. Risk of progression to thrombosis or recurrence is around 2% for both arms and in both studies. And the risk of bleeding is around 1.5% in both situations. Now, for rivaroxaban, the Einstein program, Einstein DVT, Einstein PE, again, they come 15 milligram BID for 3 weeks, followed by 20 milligram once a day. And again, large number of patients, more than 8,000 patients that were enrolled in both trials. And it showed the risk of progression. And all of these studies are designed to prove non-inferiority. So they are not statistically significant for superiority. They are statistically significant for being as good as the traditional anticoagulation. So risk of recurrence or progression of thrombosis, 2.1% for rivaroxaban, 3% for warfarin, and the risk of bleeding, major or clinically relevant non-major bleeding, is 8% for both, and around 10% for the PE study. And the risk of recurrence is around 2% in both situations. So very close numbers to the standard anticoagulant therapy. This is shown in a graphic manner. Curves are almost overlapping with regards to the risk of progression or extension of thrombosis in the range of 2% only. Again, the bleeding risk is, as you see here, not statistically non-significant difference between rivaroxaban and enoxaparin, but there is a small subpopulation that showed benefit and significant reduction in the risk of bleeding, up to between 50 to 70% risk reduction of bleeding in rivaroxaban in cases who had old age or significant renal impairment. The apixaban is studied in a big study called Amplify study that included 5,400 patients, and the risk of progression is around 2.3% for apixaban, 2.7% for classic anticoagulation, and the risk of bleeding is nearly 1/3 for the apixaban compared to the traditional anticoagulation. I'll not talk more about edoxaban. This drug is not available in the kingdom, and I think it will take some time. It is the last of the drugs to be approved for the indications I just mentioned. So you see the risk of recurrence or progression here, 2.3 versus 2.7%, and the bleeding risk is reduced by 2/3 with regards to using apixaban. This is a meta-analysis published in Blood, 2014, and looking at all the new oral anticoagulants and the hazards of bleeding, of progression of thrombosis in pooled analysis of both DVT and PE or individual disorders. But you see the trend is better or best for apixaban, followed by rivaroxaban, maybe you can say edoxaban, then rivaroxaban, and then dabigatran. Now, bleeding, they are all in favor of the new oral anticoagulants compared to warfarin. This favors warfarin, and here it favors the new oral anticoagulant. So both major bleeding and major and clinically relevant non-major bleeding were all lower in the new oral anticoagulants compared to the standard anticoagulation. Very briefly, the real-world trials, whether it is different from the clinical trials, and there are five registries that record the clinical experience of the new oral anticoagulants, mostly on rivaroxaban, compared to the traditional anticoagulation. And this is one of the studies, ZALIA study, real-world rivaroxaban in symptomatic venous thromboembolism. And in short, most of the numbers are very, very similar to the results in the prospective randomized controlled trial in the Einstein program. But there are a few, fewer, more younger patients and fewer patients with underlying cancer in those who received rivaroxaban compared to the vitamin K antagonist. But otherwise, the risk of recurrence, the all-cause mortality, and the major bleeding and fatal bleeding, it was not statistically different, although the numbers here is higher. But I think this study is just a registry. It's difficult to conclude that the mortality is reduced with rivaroxaban compared to warfarin. This is the German registry showing that the risk of bleeding over 3 years is almost maximum reaches 6%. It's around 2% per year. Now, a very important notice is that most of these bleeding episodes, 66 major bleeding episodes, 60% of them were managed conservatively or by methods that did not just supportive care, including packed cells, fresh frozen plasma, PCC, and the rest of the patients, 1/3 of those bleeders required specific reversal. So this study showed that the new oral anticoagulants are not worse than the outcome reported in case of major bleeding associated with vitamin K antagonists. Last few slides is then the risk-benefit profile of direct oral anticoagulants in established therapeutic indication. This is systematic review, an overview of systematic and observational studies. So to cut it short, that the real-world data from observational studies are in line with those from randomized controlled trials, supporting the notion that in non-valvular atrial fibrillation and in VTE, oral anticoagulants, new oral anticoagulants, are as effective as vitamin K antagonists and are safer in terms of intracranial hemorrhage. But there are some issues regarding the risks of GI bleeding with the new oral anticoagulants, and they are suggesting, the authors suggest that head-to-head comparison in the real world is needed, specifically to look for the subpopulation of patients with cancer, for example, who may have nausea, who may have mucositis, and may not be able to tolerate the oral medications compared to new oral the standard anticoagulant therapy. And also the interaction with the polypharmacal therapy may also influence the efficacy of these drugs. So they suggest that continued monitoring by regulators, pharmacovigilance experts, and clinicians is mandatory with regards to the use of the new oral anticoagulants. So in conclusion, landmark trials have shown that direct oral anticoagulants are as effective as conventional anticoagulation and with the vitamin K antagonist. Recent guidelines have changed their recommendations in favor of direct oral anticoagulants. The initial management of PE, as suggested by our previous speaker, that in high risk and intermediate risk, they are not included in these trials, so they should not be treated with this manner. They should be admitted to the hospital and managed accordingly. Although most of the other PEs can be managed safely as outpatient. And clinicians have to be familiar with these drugs regarding choosing the appropriate drug based on individual patient characteristics, coexisting drugs, comorbidities, renal impairment, age, weight, and I went through briefly the management of bleeding in such patient population. Thank you very much for your attention.